All right, we are here, everybody, and we are live with Alicia and Jennifer. How is everybody doing?
We're doing great. I want everybody to truly appreciate my Superman curl that showed up when I did my hair today.
Nice. Nice. Shout out to the CCO shirts, all matched up here,
That's right.
guys.
We all look good.
If you haven't seen Boyd in a while, this is my COVID-19 beard. Just a touch of gray. Yeah.
Mountain man beard.
Yeah. Yep. So I don't know when I'm going to get rid of it when it itches. I can't take it anymore. Put it that way. So welcome everybody to the Q&A webinar from May 2020. Along with me, I'm your host, first of all, Boyd Michael Staszewski here from Flint, Michigan. Jennifer Saunders down in Maryland.
Southern Maryland.
Where you got two houses, if I remember. Where are you today?
Oh no, I'm in Southern Maryland, and yeah.
Awesome.
Otherwise, it'd be Central Maryland.
Cool. And
But she
Alicia
still lives in
is in Texas.
Texas, right in the middle of Texas.
And we're having fun with the internet today, so just go with the flow, guys, because we're going to be playing with whatever happens.
We are
today.
having fun.
We got. Hopefully, you can hear Jennifer, who's on the phone. She was having issues, but let us know. Yeah, we're good. Okay, so please, why don't you go ahead, Alicia, while I work on all my issues over here.
All right. So if it's your first time being at the webinar, hey, we're glad to have you here. It's a lot of fun. We cover questions that were submitted to us, and usually ones that need a little more investigating or research. And then we create answer sheets and let you know what we came up with. We can have topics that are pretty basic and pretty in-depth, but we cover everything that has to do with medical business and certifications, coding, billing, practice management related. It's really interesting, some of the stuff that comes through. Now, if you can't hear us in the chat, go ahead and let us know. But heads up, we can't hear you. You can't hear anybody else except for us. And then we can see the comments that you make in the chat, but nobody else can see them unless we respond. That's the way that GoToWebinar works. But the great thing about GoToWebinar is we can have 999 people watching live. We just can't hear anybody. So the first thing we want to do is have a poll. We want to know how many of the CCO webinars have you attended, and I can launch that. Let's see here. I'm getting pretty good at it. Now, I'm not as good as everybody else, but I do make mistakes. So here we go. Your options are, this is the first time. Woo woo. We like saying that. We're back for more. A repeat offender, 2 to 5. If you've been to 5 to 10, liking it here at CCO. And then we have our always wonderful frequent flyers that have gone to 10 or more of our webinars. And it doesn't have to be just the Q&A webinar, right, Boyd? We can even include our club webinars that we have every week and our student webinars.
Sounds great. Yep.
We do a lot of webinars during the week. There for a while, we were doing almost 4 a week. All right, we are at 75%, so I'm going to count down, and then I'm going to close the poll. So hurry up, get your vote in. 5, 4, 3, 2, 1. Okay, we're going to share now. It looks like we have got, wow, a lot of new people, 36% new people. Two ends of the spectrum, it looks like, right?
Yep. 8% back for more. Just number 1, 2 to 5, 18%, 5 to 10, 12%, and 10 plus CCO frequent flyers is 26%. Nice. Welcome, everybody.
That's great. So just so you know, again, if this is your first time, we really enjoy providing these free webinars for you, and they are the questions that people out there, our peers and coworkers, have submitted to us, and we enjoy doing the research for them. So tonight, the way that's set up, we do this quick little introduction. We also let you know about people who have recently passed, and there have been times when we've had 5 or 6 slides on that, but now we only have one tonight because nobody's testing, quite obviously. And then we have some other information about CCO. Jennifer, do you want to tell them the subjects that you're going to be covering tonight?
Yep. We had a question come in about somebody who's going to begin in primary care. So what are some of the basic billing information they should know? Behavioral health is on the rise right now. So how about behavioral health in different situations, hospitalizations and locations? And then modifiers to use with office visits.
Mm-hmm. Now, as some of you may know or may not know if this is your first time, Jennifer has multiple credentials, more than is under her name right there, which they'll have them on her answer sheet, but she's our billing specialist. So we were just talking about that before we came on air. Tonight, my 3 topics is one about cancer, history cancer, and dividing up primary, secondary, and a history of cancer. Also, we had a question come in about the RAF score. And so we're going to talk a little more in depth about that. How important is the RAF score and risk adjustment? And then we had a really interesting one come in about additional training for a coder. You know, what else do we need to know besides what we get for our credential? The webinars that we do, this public webinar, we do the second to the last Thursday of every month. It's 60 minutes long. And at the end, we have time for some Q&A questions if you want to submit them as we go along. We also want you to stay till the end of the 60 minutes, because we're going to draw a prize. We're going to have a winner, but you have to be here till the end. Anytime you want to ask a question, again, do so in the chat. We have multiple eyes looking at that. We can't get to every question, but we do our best to do that. If you have a really good question or a topic that you would like us to cover in a webinar, and you may not know what type of webinar you want us to do it in, but if, like this public webinar that we're doing, all you have to do to submit that is go to cco.us/topic-request, and then maybe we'll be answering your question next month. The giveaways that we have, they're a lot of fun. Again, you have to stay till the end, because we have a way to check that through GoToWebinar. You can pick one of our blitzes if you would like. You can have a phone session with one of us, an hour phone session, or better, the best one is a year worth of our CCO Club. And we'll talk about the CCO Club more in depth in a little bit. Like right now, I guess. I didn't look ahead to see what
it's going to come up later too, so you can just give a short
yeah.
version.
Okay, the CCO Club is amazing. We do webinars every week for the club. We have student webinars as well. And again, these are relevant topics, mostly questions that have come into the club, but you can earn CEUs through the club. Awesome opportunities for specialty credentials as well. They're always difficult to find, especially when you're scrambling to get them at the end, if you're one of those that waits to the last moment. We also have a lot of fun doing them, so it's never going to be boring, dull. We want them to be as informative as we possibly can make them, but still let our passion for what we do kind of shine through. We have support calls. We have all of our videos that you may see highlights in our YouTube channel. Maybe that's how you found us, but more in depth with the answer sheets and the slide decks and transcripts. All of that stuff is in the club. And if you get one of our courses, and even after the course is over or expires, if you're in our club, you don't ever have to lose that content, and you get it upgraded free when the new year comes around. It's time for another poll. What is your status in medical coding, billing, or similar medical business related jobs? I'm gonna look here real quick. I'm being very careful to hit the right one, because last month I hit the wrong one.
I updated your slide for the graduates, by the way. So you may want to refresh it, because there is no graduate slide. There's just a title.
Okay.
Yeah. So you may want to refresh that while this is going on. So are you looking at medical coding as a career? Are you certified and looking for a job? Are you employed, or are you improving your current job situation and trying to earn a new credential? Or none of the above, not pursuing employment at this time? What is it? We're going to rock and roll here today and punch through this and get you guys back on your merry ways. What do we got? We have 65% voted, it looks like. So I know I like the guys in YouTube are winning tonight over the guys in Facebook with comments. You guys rock in YouTube.
You know what? That's another thing everybody may not realize, that not only do we have people that are here live in GoToWebinar, but we also are set up Boyd live streams on YouTube and Facebook. And are we on LinkedIn tonight?
No, we're not. So comments in from YouTube, we're studying for CPC.
Sometimes we even live stream on LinkedIn.
Yeah, certified, looking for a job, improving current job situations. We got one for each of those, it looks like, over in YouTube. Share that poll,
wow.
Alicia. I was going to call you my daughter's name.
Closing.
You there for a second.
And sharing. That's all right. That's all right. I was calling my son-in-law the dog's name when they came down last weekend. 17% looking for a medical coding career or as a career. 19% looking to get that job, which we've got some information about that tonight. 38% is employed. 24% improve my current job situation. And 2%, nope, not pursuing employment at this time. Excellent. Okay, so is that supposed to say pause? Did you put that on there, Boyd?
Nope, go ahead, just take it off.
Oh, is it? I didn't know I could take it off.
Well, take it.
What did it do?
I don't know.
Okay,
I'll
I upgraded it.
I hide it.
I mean, I did what you told me to when during the poll.
I hided it.
You hided it. Okay. Now, did I share the poll for you guys?
Yes.
Okay.
We're seeing
All right.
Yeah, we
That's
saw
out
it.
of the way then.
Yeah.
Okay. I'm getting ready to move over the answer sheet. I'm going to take my face off here, and Jennifer's going to read off this slide, and then I'm going to move over that answer sheet for her.
Okay. So one of our questions that came in is they're wondering which modifiers do we use when the doctor does multiple procedures during a visit. And their example was like an X-ray, an EKG, vaccinations. At the same encounter, which procedure gets the modifier? Now, modifiers are always tricky. Sometimes it takes that attention to detail, and sometimes it's that, you repetitive, you use it all the time, so you're quite familiar with it. So they just take a lot of practice. Knowing where to find them, too. We've got the CPT manual modifiers, and we got HitPix modifiers, which number in the hundreds, I think. I mean, quite a few. So modifiers and office visits commonly are used together. So you typically may find modifiers used in an office setting. So many different offices and many different specialties provide services to a patient in addition to an evaluation and management. So evaluation and management is our office visit code, and then there is typically other types of procedures that we find done during that same encounter. Like a dermatologist, they might remove a mole the same day as the consultation that they were sent for. Cardiologists, they might do an EKG on the same day as the patient's office visit, kind of make sure everything's still going okay, or maybe they had a recent episode and they want to double check it. Or your primary care doctor may give you a tetanus shot after you've been bit by an animal. So there's a lot of different times that we're going to see an office visit and a procedure of some sort being done at the same time. So in these cases, you might see a 25 modifier used to describe that additional service that's performed on the patient, because 25 modifier is very tricky. So how do we know when to use that 25 modifier? So there's some questions, and this actually came off of one of the MAC carriers, CMS, and with each of these questions, they actually answered it for you. So I did provide the links in case you want to look at some examples or scenarios that they have. But are there signs, symptoms, and/or other conditions the provider must address before deciding to perform a procedure or service? This is where we get into some of that medical necessity. They have to address these things before they're going to do something else. And like I said, this MAC carrier gives examples as well. Were the provider's evaluation and management of the problem significant and beyond the normal preoperative or postoperative work? Because remember, with a procedure, certain things are inherent with a procedure. Preoperative and postoperative work being one of them, depends on the type of procedure that was done. Was the procedure or the service scheduled before that patient came in? So did we already know that they were coming in for a tetanus shot? Did we already know they were going to have an EKG or an injection before they came into the office that day? And is there one or more diagnosis or diagnoses present that are being addressed or affecting the treatment and outcome? So this came off of a Novitas solution. It was actually the JH area. So they present each of these questions, and then they describe a scenario, and then they answer it. So they provide the feedback as to how they come up with that answer. So it was a nice presentation into it to know if we have to include a modifier as well when certain situations are done. So the American College of Cardiologists, I went to their site, and they also had some further questions that we need to look at. When you build both codes on the same day, does your documentation support it? Just before everybody came on, I was telling Alicia that our webinar last week that our chapter held was with Michael Misko. If you're part of AAPC, you might know that name. He's president of the NAB, the board of all the AAPC chapters, and he is a lawyer. So he actually, this is what he presented to our chapter was, is your 25 modifier defensible? So it's very interesting, and this is actually one thing he mentioned, is can you separate out, imagine if you were to separate out that documentation and have just the procedure and just the office visit, are they going to stand alone and be able to support both codes being submitted? And then have you documented a history, exam, and medical decision-making, or two of those three, depending if it's an established or new, separate from the procedure? Or is that procedure part of that medical decision-making or part of that examination? Can you not separate them out? So we need to know if it stands on its own and if it is medically necessary. And if you've answered yes to most of those other questions, then we can include a 25 modifier along with these procedures. How do we know when to include it? Sometimes CPT tells us. An example of hydration, it says, if a significant separately identifiable E&M service is performed, you should report a 25 modifier along with these hydration and infusion codes. So a different diagnosis doesn't have to be reported. Now, a lot of times people think, oh, well, I have this diagnosis and, pain and then fracture. Well, is the pain caused by the fracture? Could be, but you don't always have to have a separate diagnosis. A lot of people think that, because remember, if you can stand on its own saying that these things had to be done in order to perform it, then you can include it. Other times we rely on NCCI. So NCCI is our National Correct Coding Initiative. And this is a website. It used to be manuals and thick books that we did every quarter, but now it's all lovely on one website. So in the case of, we looked up hydration. I did 96360. And it runs for a long list on this Excel spreadsheet that you can pull up. But as you see those office visits in the second column there, we recognize some of those E&M codes. Now you go all the way over to the fifth column there, and we see ones and zeros in there. That NCCI table is telling us that an office visit could be payable with infusion that 1 indicates the modifier could be used when appropriate. So remember, all those questions we asked, can it stand on its own? Did we do all 3 elements or all 2 elements of our Enm? 0 indicates it's not allowed. So if you go looking down that list, 99211 nurse visit, we are not able to include an office visit with 96360 with a infusion or hydration service. We can't bill a 25 modifier with that. It's telling us no circumstances, no way, not allowed. So not all codes require a modifier when they're used together. So for example, an x-ray could be done by a podiatrist or an orthopedic provider. They have equipment in their office typically to do this, and they might do it the same day as the patient's seen. The CPT manual doesn't tell us that an x-ray is inclusive with an Enm. So in the beginning of the 70,000 section, when it gives some of the guidelines, it doesn't describe it. And next to the code, it doesn't say to bill at all. Then if we were to look up a certain code on the NCCI edit, we're doing a foot x-ray, 2 views. There's no Enm codes listed there. Those are all the codes that can that have an NCCI edit with an x-ray. So they don't include the office visits, meaning there's no standards or no guidelines that those codes should be used together or not, or need a modifier. So typically, yes, we can bill them together. Something I used to do every single day. Well, what about that EKG and other multiple procedures that they mentioned? So there are questions that an X-ray, EKG, and vaccine. So most services aren't similar. They're not inclusive to each other. For example, a knee X-ray was done on the follow-up from the surgery on the same day that they did an EKG because they said I had some chest pain, and then they gave them a flu shot because they're there and it's November and it's flu time. So you could do all of those together, yes. They don't require modifiers necessarily. Those that may need a modifier could be indicated in the NCCI edit. And we'll go down a little bit more. And so a primary care provider really could do all of these things. But if we go look at the X-ray example, we had a foot 73620. And it can't be performed with some of these other services. And I briefly described what they were. That's what was on that table, that chart that we gave in the last example. So collection of specimen or irrigation of an implanted venous access device. For some reason, you can't do a foot x-ray on the same day as those. I'm not a specialist in those areas. I can't tell you why. But it indicated it could be used with a 73660 when modified when appropriate, which is toe x-ray. Well, how can you take x-rays of your foot without taking an x-ray of your toe? So typically that's inclusive. So if we use that logic that, of course, if you're taking a foot x-ray, your toes are included on that. And look, how would you have any different view of your toes that you didn't have of your foot? So we can see how that could need to be modified. Here's our example. The patient ran into the couch, stubbed their toes, and then fell and hit the other foot on the coffee table. Okay, we can see that happening. We can imagine that. So one x-ray is performed on one foot, the other is on the other side. So there are separate services that would require a modifier. So the diagnosis could be different. We could say it's all foot pain, or the diagnosis showed a fracture of one area, and fracture of the foot, maybe the toes were just bruised or something. So their diagnosis could mean laterality. If you know fracture diagnoses, they go by left and right typically. So if that's the case, it could be possible a different diagnosis, but it's not required. What if we have pain in both my feet? They took x-rays. They both are being billed with foot pain or toe pain, which is the same diagnosis, maybe for both feet. So we're going to modify it somehow with the insurance carrier, whether they require a left and right, or however the carrier's requirements are, or 59. We'd modify that to say these are separate services. Now the EKG, it can be done on the same day as the x-rays and an immunization. So NCCI, if we look up this EKG, we don't see an immunization code there. We know those all begin with 90,000. That's not listed. and an x-ray. Those are $70,000. Those are nowhere on this list. Those can all be performed together on the same day. NCCI says there's no modifiers required. So some areas of CPT do indicate that you need a modifier with multiple services. Again, going back to hydration, it specifically says that in the section that it requires a 59 modifier, specifically under the initial hydration. You only bill one initial hydration, except unless the protocol or a patient condition requires that two separate IV sites must be utilized. The difference in time and effort in providing that second site is also reported with an initial service. So they even give an example. You bill 96365 and 96365.59 because for some reason this patient required two initial ports of IV infusion. Sometimes things like that happen. So there are cases where we would need a modifier to remember, modifiers describe our story. So we tell the insurance company the patient came in for an office visit and had this service that day, but it describes the story that these are separate, that they're two different identifiable problems. Now, CPT says modifier 59 is used to identify procedures or services that you don't normally put together. You don't normally do those two different toe and foot x-rays because toe is inclusive in the foot, but you can do them separately because it could be a different site, a different session, different encounter, different surgery, different incision. There's a lot of things described in the 59 modifier. However, when another already established modifier is appropriate, it should be used instead of 59, such as those X modifiers, XU, XS, or more appropriate, left and right, or anatomical identifier, E1, or F4, for your finger or your toe or your eyelid. So there's a lot of different modifiers that should be used in place of the 59. Some carriers like them, some don't. You just gotta, you bill the way you would normally bill things and we'll let the billers and the carriers figure that out. But as far as which procedure to have modified, so how do we know which one to put the modifier on? Typically, you would bill it as the secondary, the additional, or the lesser procedure that the NCCI edits say. So you think of it the way that we talk about CPT, of the most expensive procedure goes first, and then the additional procedures would, the lesser procedures would go secondary. Those secondary or lesser procedures, those receive a 59 modifier or right, left, XU, whatever the case may be of the modifier that is necessary. Medicare, great site. I talk about them all the time. CMS has a modifier 59 PDF, which is actually pretty well put together, describes a lot of different scenarios, describes all the X modifiers, gives you scenarios for the X modifiers, because those are kind of confusing. They came out this past year. We should be using the X modifiers instead of 59. So if it happens to be that an X modifier fits your situation better, we should be using that instead of a 59 modifier. But great information from CMS, as always. They love to put out some good information.
Thank you, Jennifer.
Mm-hmm.
Yay, good stuff. We were talking about modifiers right before we got started. What core coding credential do you want next? And I will launch that. Hold on just a second. I got the polls in the wrong, or let's do that next one. There it is, launch. Do you want the CPC or the CCSP? That's kind of the counterpart with AHEMA. The COC, the CIC, or the CCS, which are more facility type credentials. The CPMA, which is auditing. The CRC, which is risk adjustment, or other. And make sure that you put in the chat which one that you're looking for if it's another.
What's the latest on testing? Any heads up?
I haven't heard any updates.
Yeah.
Yeah, as far as we know. Have you?
It is up to your chapter. So a lot of people get upset at AAPC. It is up to the chapters. So if the chapter has a facility they can use, because remember, your state might be open, but maybe, the hospital still isn't allowing meetings, or a school or something like that. So in our area, we can't even look at one probably through the end of the year.
Wow.
So, yeah. So unless we can find a decent place to use, but most places aren't open. So
my word.
The online option, there's a lot of information about it on the AAPC website if you're looking at online, but it is only for the CPC.
Good to know. Thanks.
Oh, right. We're going to close this poll. You guys, anybody else? We got only 66 voted. Oh, come on. Wake up. It looks like somebody said the CDEO. We have a course for that. That's great. And there's a sale going on right now. Okay, I'm going to close it. 5, 4, 3, 2, 1, and bam. And so it looks like CPC, CTSP, that's our number one at 32%. We've got those facility credentials at 22%. Only 9% said the auditing, CPMA. CRC, 18%. Woohoo! And then 19% said other. So make sure you let us know what you're thinking about with the other one. Ooh, my question's next. Fun. Okay, guys, I kind of was keeping an eyeball on the chat questions, and you guys had a lot of questions come in regarding this cancer stuff. So primary, secondary, and history of cancer. Our office is having a debate about a patient who has prostate cancer that is now in the bone. The doctor documented that the patient had a history of prostate cancer, and now they have found cancer in the femur. From the documentation, I feel the prostate cancer is no longer a history because it metastasized to the bone. The thing is, the patient had a prostatectomy, and so some are saying that the patient can have prostate cancer again. I've looked for clarification. I can't seem to find anything one way or the other that is defining how we should code this. We love the CCO videos. Thanks, Sammy. Yay, Sammy. Okay, well, I got an answer for you. And I did not get a bunch of pictures of prostate cancer. Because you know I like to do crazy things like that. The thing of it is I can give you some examples of other types of cancers, but they specifically asked about prostate cancers, and I saw some of you in the chat have asked about other types of cancers like breast cancer after a mastectomy. I went to different medical articles to see if I could find something that you could use to give you that link. I agree with you that even if a person has had a prostatectomy, they can still have prostate cancer. And there's a reason why. It tells us in this medical journal, which I put links in there for you guys, but that it's possible for you to have a return of prostate cancer after a prostatectomy. They did a study in 2013 that said actually 20 to 40% of men within 10 years of after having a radical prostatectomy, meaning not only did they take the prostate, but they took tissue around the prostate margins and stuff, that had a recurrence of it. So even though you remove the organ and the surrounding tissue, the fact is once you have a cancer cell, it could always come back because the cancer cells can be floating in the body. And a really good example of that, which I think I gave somebody one time, is like your a regular cell looks like a piece of paper, and you see I write notes on stuff all the time. And when the cancer cell starts to get, cancerous changes and abnormal, it will change shape. But it's still, you can throw this across the room and it doesn't go anywhere. But if you take it like this, which is a cancer cell, and you throw it, it likes to move. An abnormal cell takes off. That's why we have metastasis. So even though there is no prostate, we don't know 100% for sure that there are not prostate cancer cells floating around in the body. And when they do, they like to go to specific areas. We know that because of the statistics that we've collected. And this little graphic right here, which I know that's kind of small, tells us where one of the places it likes to go is the bone, and it likes to go through the lymph nodes. It goes from the prostate, which it shows here right underneath the bladder, which the prostate's really tiny. It likes to go to the spine, the pelvis, and the hip. And this one documented it showed up in the femur. I found another article from Johns Hopkins Medicine that said that even if you have a PSA, you've had a prostatectomy, if you have a PSA that doubles in less than 3 months, that's a negative sign that you could have a reoccurrence. If it goes between 3 and 9 months for it to double, or if it between 9 and 15 months or greater than 15 months when the PSA doubles. And the PSA is a blood test. That's a protein that they're able to check that tells you if you have more likelihood of having prostate cancer. There's also a Gleason score. Take time to go out and do your research. Write down on a little notebook right now, what is a PSA, what's the Gleason score, et cetera, et cetera. I encourage you to do that if you're doing any type of coding, because almost every man that after they turn 65, they're going to have some kind of problem with their prostate. So it's a good idea to be aware of this. Then it went on to say that time from surgery to the return of the PSA, the elevated PSA, did it return within 3 years or afterwards? So even if a patient has had a prostatectomy and they don't have an elevated PSA for an extended period of time, doesn't mean that there's not cancer cells, or there could be other things going on in the body, because it's a hormone. It's part of the endocrine system. So again, there's other reasons to have an elevated PSA, but Johns Hopkins is a trusted source to look at. Now, in theory, they did go on to say that when you have cancer cells of the prostate, they can go anywhere in the body. And that because of that, that when these cells break off and just float around, are they going to attach somewhere? Well, these are the more common places that they like to attach. They've done these studies with all types of cancer, whether it be a solid cancer or a liquid cancer, but I would encourage you to familiarize yourself a little bit. Don't memorize it, but prostate cancer is pretty common, as well as breast cancer. So bones, lymph nodes, lungs, liver, and brain, that's where prostate cancer likes to go. And honestly, breast cancer kind of follows that same trend. There is a whole list of less likely areas, but I didn't put that in the list. You guys can do your research on your own. You need to be learning to research anyway. Cancerous tumors are malignant tumors. This is what the guidelines tell you. The uncontrolled cell growth makes it metastatic. Okay, so you could have uncontrolled cell growth that's benign, meaning it doesn't go anywhere, it just gets bigger, and that's problematic. But once it starts to move, like my little wadded up piece of paper, then it's metastatic. It attaches someplace else. And whenever you're coding this, how you would code this particular scenario is that the primary malignancy, which was the prostate cancer, will always be coded as primary, which would be a C code. And I've got it written down, but I can't remember what it is. I think it's like C61 or something like that. And however, if it metastasizes to the bone, then that will be a secondary cancer. That's what that means. Primary is the first place that they discover it, and then secondary is where it metastasized to. And don't just think it's the first place they discovered it. They actually go in and do a pathology test, and they say, hey, how come we have prostate cells in this tumor that's in a bone, it doesn't go here. So we know, because of the pathology test, that we're not supposed to have prostate cells in the bone. And so the primary cancer is the prostate. Secondary cancer is the bone. That's the way they do it. That's the way that if you look up the tumor registries and you learn how to read those, which is relatively, and it's very interesting and pretty easy to learn for coders that pick it up pretty quickly. However, don't think that you can't have multiple cancers in secondary, you can have multiple secondary spots. So let's say it was found in the bone and then also in the brain. So they would go in, there's a tumor in the brain, they biopsy it, and it's prostate cells. Then they know the prostate cells have moved, they've metastasized to the bone and the brain. So those are both secondary cancers. That's a different code. Usually starts with the D, or a higher C number, secondary, because it's just alphanumeric. Okay. Now, let's just look at the scenario. Malignancy of the prostate, whether the prostatectomy has occurred or not. But even if the prostate is gone, that doesn't mean before it was removed, an acquired absence of the prostate, that those cells have not sloughed off and gone throughout the body and just finally reattached themselves to another place that it likes to go, thus the bone. And you may wonder, why does it like to go to things like the bone? Because it rides through the lymphatic system, which is is a liquid system throughout the whole body, but also the blood. Well, what does the bone do? The bone marrow makes blood components, right? So there's a relationship there. That's why it likes to do that. When you go to code cancers of prostate, heads up, there's a code for R97.21, which is a rising PSA, that blood test that I told you about, for malignant neoplasm of the prostate. Just a heads up, you might be wanting to include that if it's applicable in your documentation. Secondary cancer of the bone, C79.51. Okay, so prostate cancer, C61, and it's metastasized, whether there's a prostate or not, to the bone, and that secondary malignancy is C79.21. It does not matter, which I don't know if I put another picture, I didn't. It does not matter, the codes never change, but the sequencing of the code changes. Now, we're not going to treat the prostate cancer anymore because honestly, the prostate's gone. What's there to treat? However, it's the primary cancer. So we're treating the bone now. So you will code C79.51 and then C61. So the question is it a history of prostate cancer? No, it's not, because the prostate cancer is active in the body. The cells are active in the body, just another place. Okay, so it is not a history of prostate cancer. They will get documented that way because that's the way providers document it, but that's not the way we translate it. We can query the provider and find out. Now, another question that came in that's applicable to this is breast cancer. If a person has bilateral mastectomy, the provider documents that it is eradicated, there's no more tumor, okay, but they choose to have the patient for the next 5 years take a medication that helps prevent them from having a recurrence. There's more than one type of drug, and there's a couple different schools of thought about this. Is this a prophylactic medication being used? Is this active treatment, et cetera, et cetera? So what I encourage you to do is, in the office that you're working in, then you as a group with the provider and your, even the clinicians and the coders and your compliance officers, you decide how you're going to code that with the scenario as an example to say, okay, this is going to be our protocol. When I put a patient on this particular medication, I'm actively treating it. Or no, this is just to prevent it. They'll take it for 5 years. They have no, we're not aware of any cancer in their body at this time. My way of thinking, it doesn't really matter what I think, it's whatever you guys decide to do. But if you're going to do a test question, most likely they're going to test you and they're going to imply that it's a history of cancer. If a person has prostate cancer and they say a history of prostate cancer, but they're on the medication for the next 5 years or the next year or so of, I think it's called lufenifline or something like that, that's for treating advanced active prostate cancer. So it's not a history of, because that drug is used for active cancer. Whereas the medication that the person that asked in the chat was talking about was a medication that is used to prevent a recurrence of breast cancer. And there's, as we get more and more knowledge regarding how to treat and to prevent the reoccurrence of cancers, these drugs pop up. So have a policy in place. If the provider states that it's the history of breast cancer and I'm putting this on this patient prophylactically so they don't get it again, then to me that's a history of. They don't actively have the cancer. But again, we only translate what the intent is. And so the provider tells us, no, I want you to say that they have cancer and that's why we're treating it. Because quite honestly, it doesn't matter what kind of cancer you have. Once you have cancer, you always have cancer if you ask an oncologist. Those little cells can be floating around in the body. You never know. And liquid cancers like leukemia and stuff like that, spinal cord cancers, actually never go away. They kind of go in remission. So this is a really fun question. I enjoyed talking about that. And we talk about it a lot as educators because you get tested on it a lot. I hope that helped. And next, we have a great sale going on. So if some of you that were talking about the other credentials you'd like to pick up, great time to do it, because what else are you doing? You're stuck at home in a quarantine. Might as well take an online course, kind of going that way anyway, right? With online courses, there's 30% off, and that sale is going to expire the 23rd at midnight. If you want to find that sale easily, you can go to cco.us/super sale. And again, or you can just go to cco.us. It's probably splashed on a banner. Maybe you're not ready to take a course right now, or the Blitz or some of the other products that we offer, but you know somebody else that is thinking about doing it. Feel free to share. Send a message in or send them this link. Just tell them to go to cco.us. We'd be more than happy to answer some questions and get them fitted with the right course. And next is a billing question. Are you there, Jennifer?
Yeah, I had to unmute. Sorry. Okay, so for somebody who is transitioning in their career and they're going into primary care, so what are some of the billing guidelines, and can we narrow down some of what needs to be focused on? So it's kind of interesting that I had both of these questions. They kind of one set off the other. I actually started discussing modifiers in this question, and then I got to the next one going, wait a minute, that one's all about modifiers. So I tried to go back and make this one more specifically about some of the billing guidelines. So primary care does see just everything walks through the door in primary care, so many reasons. So your cold, your flu, allergies, scrapes, cuts, even broken bones, even cardiac issues. Because your primary care, they might have an HMO plan. So they can't always go to that specialist that they want to go to when something happens. They might have to go to the primary care first and then go to an orthopedic or cardiologist or dermatologist or any of the other specialties that are out there. So primary cares are those gatekeepers for those specialties, possibly if they have a plan that requires a referral. So there's so many different things coming through the door. Primary care, you need to be familiar with lots of minor procedures, and that's some of the modifiers that we were discussing with that 25. The modifiers, you have preventive care codes that come through the door, all your wellness visits, your annual physicals, and of course your evaluation and management guidelines are very important to know when to use that 25 modifier. When is this patient new? When are they established? So evaluation and management codes is the number one thing, of course, that's going to go through a primary care office. Pretty much everybody's going to have an evaluation and management code unless they were scheduled for some other reason, like specifically to come in for an allergy test or something. So understanding the rules of leveling is to know when to use the Enm code when a procedure is also performed on the same day. So it's important to know those rules of your Enm leveling, which understand that we had this question pop up in the chat. In a certification exam, you don't have to level. On the CPC certification exam, you're not leveling an Enm visit. So don't get too involved in is that 4 criteria or is it 7 or 5 or, how many HPI elements are there? That is not going to be a test on the CPC exam. But knowing how to level when you get into the field, just being familiar with it, and it takes practice. So many patients come in to primary care, of course, for those annual physicals. And you would need to be familiar with the different insurance carriers' rules. They might say specifically 1 year. So if they came in on April 1st last year, they cannot come in on March 25th the next year because it needs to be specifically 1 year. They may have guidelines such as that, or those child ones where they come in every 3 months. An insurance company may specify a specific time that it must be 90 days apart, at least. So we need to know those different codes when they bill. Primary care, there's the pediatric, we see geriatric. So when can those immunizations be given? What kind of codes do we use? Knowing the insurance carriers, keeping up on their websites, especially right now with COVID, those things are changing, no lie, daily, always making changes to them. They're extending deadlines. They're changing the modifiers they want to use because they figured out, wait, we can't track that criteria, so let's try it this way. Being able to know the difference. So subscribe to their listservs. Get their monthly newsletters so that you can be caught up on all this information. Minor procedures and other medical services are typically done in a primary care setting. I've worked in primary care before, and we really do. You see everything comes through the door. Allergy shots, maybe the allergy tests where they prick the skin, immunizations, of course, for all different kinds of problems, not just flu, but, all the HPV and tetanus and the crazy ones, that if somebody's going out of the country and needs some odd immunization. Cortisone injections can also be done in a primary care office. Nebulizer treatment. They're not breathing properly. The pulmonary the PFTs. Hydration. We used to do hydrations on patients. Venipunctures, lab work. They may have laboratory in their office. They may just send it out. EKGs or ECGs, whichever you call it. Serum removal, earwax, very common to be done in a primary care office. Pap smears can also be done in a primary care. Biopsies, other shavings and excisions. So really, almost the entire CPT manual can be done in a primary care office. So there are so many things to look out for. Now, billing-wise, remember, it comes down to medical necessity. So the documentation has to prove the necessity supported by that diagnosis code. So being very familiar with your diagnosis codes and how to properly get to the highest specificity. And then the procedure code that's submitted to the insurance company. We need to know can those be done together as well. So the tricky part comes with that evaluation and management. And again, like we said, with that 25 modifier, is it supported to be able to do one of these other minor procedures in the office along with that office visit, that evaluation and management? Can they stand on their own merits and prove that they were done separately? Then you got to modify it. And we'll go down a little bit more. So most insurance companies allow these procedures in a primary care setting and when they are medically necessary. So we know you know that your immunizations, you got them at a certain time. If you've had kids, you take them in and they say, okay, 3 months, come back and we'll do this one. At 1 year, we do this. When you're 14, you get this. And, 21, I think they came out with some brand new ones I didn't even know the last time I took my 17-year-old in. So they're saying, okay, there's new immunizations she has to get. So that timeline, we need to make sure we're keeping track of those timelines. Lab work, if they have their own setting, lab has its own guidelines as well, different modifiers. What can be done? Because remember, certain carriers allow certain lab companies. If you have United Healthcare, for 1 year it was LabCorp, and the next year it was, I can't remember the name of any of the lab companies, and then they switch back again the following year. So you may not be able to process everybody's lab work if you have a laboratory in your office. You may have to send some out. Allergy shots. People came in for them all the time. Are you allergic to cat dander, dust mites, determining what people are allergic to? That requires a pre-certification and authorization. The insurance company might want to send that medication that they put in the skin to you. They might send it to the office. They might send it to the patient. The patient might have to pick it up from the pharmacy and store it. So there's all different kinds of things. Pap smears. I didn't know it changed every 5 years when I went to go have mine. So there's different criteria, especially Medicare. Medicare is very strict, and primary care sees a lot of Medicare patients. So if you do have a high Medicare population, I highly suggest we have other videos out there about the annual wellness visit, or looking at on the CMS website. There's a big booklet that tells you exactly everything you need to do for an annual wellness visit. Again, that modifier knowledge, knowing that at 25, I won't go into that again, but it's separately identifiable. So we need to make sure that we're using it properly. Other modifiers, 50 bilateral, 51 additional, or 59 separate, because you might be doing different things. And remember to pay attention to the CPT descriptor. Lesions. So you may not be able to bill for more than one. Remember, 1,700. Doesn't matter how many you do, or up to 15. So first, look at the common procedures that office does. Run a report. Ask the manager to run a report. What are some of the common things that we bill out? All EMR systems are able to pull this information. And look up, what are the rules for this insurance company? Then say, what are we participating for? Okay, we participate with Aetna, Cigna, and Medicare. Now let me look at the rules. Medicare says this. Cigna says we can do it more often than Medicare does. Things that you got to keep track of. So also, if we can go down a little bit more, if your program, the system that you're using, allows for alerts, those alerts are a wonderful invention that somebody came up with to say this person can't have this again for another 3 months. So that way when they schedule, they go, oh, sorry, we can't schedule you this week. We can schedule you next week, because otherwise your insurance company's not going to pay for it. Make a cheat sheet to understand which insurance carriers allow what. Letting them know 17000 procedure code can only be performed so many times a year. We saw that quite often with routine foot care, shaving of the corns and calluses on diabetic patients, knowing that they have to be diabetic to have that done. And then knowing it can only be done every 61 days. So all these different rules we need to keep track of, as well as those ICD-10s. Very important, because a lot of the insurance carriers might say, especially Medicare, We will only allow this service if they have this diagnosis. My example was the diabetes. They will only allow routine foot care if they're diabetic. So if they're not diabetic, you need to have that ABN signed by the patient to say that they're going to be responsible for that visit. Otherwise, you just granted a free service to somebody. So, knowing that those sequencing guidelines, Z23, can we put it first? Does I-10, your diabetes, your hypertension, very, very common. 3 very common diagnoses you're going to see in a primary care setting. Hypertension, diabetes, those things require a lot of follow-up, a lot of medications, and then Z23, your immunization. You're going to see that quite a few times a year, specifically if you treat Medicare patients, because typically right around Halloween time, they start saying, okay, come on in for your flu shot, and you're going to see Z23 like every other patient 10 times a day. So knowing all those CPT rules as well as your ICD-10, what can be put together, you don't necessarily need to memorize them. Make a cheat sheet. If you especially you might see them often enough that you start to remember them, but because anything comes into primary care, you may need to just be on your toes, then that you may not see it as often as something else. I don't think I have anything else on the bottom. Alicia loves little notes and cheat sheets and little sticky notes. So remember you can see anybody of any age for any reason in a primary care office. So it seems like a lot, not as much as a hospital does, but it's more than a specialist is going to do. Specialists will deal with one section. Primary care, you can see just about anything, depends on what's handled in their office and what kind of equipment they have. But then just definitely knowing your insurance carriers and what rules they have for your common services is probably the biggest tip.
I know those Z23s. I was doing some primary care 1 month, and it was like Z23, Z23, Z23 was on everything.
Yep.
I wasn't very good at it either, by the way. I'm not near as good as CPT or as fast as I am with ICD. I'm much faster and more confident. But I did learn a lot. What is your work status? Let's do a poll real quick and let everybody have a moment. Well, this is pretty funny, but are you working remote, in-house, temporary, laid off? Now, let's pretend it's not COVID-19 time. So don't say right this very minute, but as a general rule, if it wasn't during a pandemic, how would you be working? As you know, everybody at CCO works remote. So, wow, you guys are putting them in there awful fast. I appreciate that. Lots of questions coming in the chat. We appreciate those too. Thanks for all your kind words that you are submitting. Thank you. Okay, guys, I'm going to close it out. 1, 5, 4, 3, 2, 1, close and sharing. So it says 56% are remote, but I wonder if that's because of the pandemic anyway. 20% in-house and 25% is temporarily laid off. And I really think that's also because of the pandemic. A lot of people are laid off because we've done this poll a couple months in a row, and we don't normally have that high a number for temporarily laid off.
Yeah.
Yep. Okay, this is a great one because, as you know, I love risk adjustment. And so when this question came in, I'm like, hey, yeah. And I also appreciate that this person just saw a recent webinar that we did on RAF scores. I'm still trying to figure out how the RAF score works in HCC coding. I watched your video on this subject the other day. Thank you for that. But I'm still confused on why we need to know how that works. If I want to get the CRC, am I going to be working with the RAF score much? I am so If so, I'm worried I will not be able to do this type of coding. I love working with ICD, and so figured the CRC would be the next credential I would get. Well, I think that's brilliant, because if you love working with ICD, then yes, it's going to be right up your alley. However, the CRC credential itself is not all about ICD-10 coding. It's predominantly, I mean, that is the only code set you'll be using. However, it is not the only thing you need to know. There is, for that credential, there's a lot of the behind the scenes things that you need to know. And the RAF score is just one of those many things. So what I decided to do, since that we did that other video here not too long ago, and I don't know, I know it's in the club, you might be able to find it on YouTube, but it was how to figure out a RAF score. You know, take some time to go look at that. So what I wanted to do is kind of reiterate some of those things that I had said, but kind of tweak it to make it in a more simplified example of why we do what we do. Now, this statement that I put in here is something I say all the time. I'm sure Boyd is tired of hearing me say this, but it is true. We code for statistical purposes. It just happens to be a convenient way to get paid. Risk adjustment is two parts. It's collecting the statistics, but it is also how we get paid. For the most part, for the last umpteen years, we have been reimbursed, our providers are reimbursed based on CPT codes, based on what we do to the patient, whether it be an Enm, evaluation and management of the patient and their diseases and diagnosis and disease processes, to the procedures that are performed to treat those diseases and diagnoses, not what the patient had wrong with them. Risk adjustment is different. It's kind of like going old school. So instead of what we have to do to the patient, it's based on how sick the patient is. The sicker the patient, the more money that's going to be set aside for the patient's care. And the statistics allow us to do that. Risk adjustment, or the risk adjustment factor, just gives a score, meaning it's not even really a percentage, I would say, but it's a number that is associated to funds. I think that's a good way to say it. So if we change the way we think about it and we get rid of the decimals and all the percentages and the algorithms that are used and everything, don't think of it that way. Let's budget by how sick the person is to make sure that we have the money set aside to treat the patient for the next year. Now, risk adjustment is not just for Medicare anymore. Medicaid risk adjusts and commercial insurance is risk adjust now, because again, it's a budget, ultimately a budget that is captured via statistics. But the word statistic is kind of scary, at least it is for me. Honestly, I don't like numbers and I don't like math, but this is not the same type of math, so it doesn't bother me. Risk adjustment jobs, I already alluded a little bit about it being, ICD-10, right? We use one code set. We are only looking at diagnoses. We don't care that the person had open heart surgery. For risk adjustment, we want to know why they had open heart surgery. Did they have an MI? Did they have an aneurysm? Did they have a atherosclerotic heart disease? Why did they have it? Did they have to have a valve replaced? That's more important than the fact that they had the surgery. Why did they have the surgery? The diagnosis. The RAF score is always applied to allow the payers, the insurance companies, to make sure that when they do a retrospective study, they have enough money for the future. So when you hear the term retrospective, it you may think retro means in the past, which I usually think retro means that, but in this instance, that's not what we're talking about. We're taking two groups of people. We're taking sick people and we're taking healthy people, and we're comparing them. So we're giving the sick people a set of numbers based on how sick they are in comparison to the people who are healthy, and then we're taking those numbers side by side, and we're saying, okay, this is how much it costs to take care of healthy people, to keep them healthy, and this is how much it costs us to take care of sick people, to make them not get sicker or get better. We don't want them to get worse. We want them to maintain or get better. So that's what retrospective study means. And we do that based on the RAF score. That's how we come up with it. So the example that I gave or came up with is the starting point is always 1. You have a RAF score of 1, but we're not going to think about that. Let's take two people. Let's take Penelope and Stanley. And since I get to do this, I get to pick the names. So I picked Penelope and Stanley because Penelope is a girl, she's a 1. And because Stanley's a guy, he's a 2. Now, this isn't the true number that they have for the score. It's a number like 0.335. It's a standard number that's given. But I'm going to simplify this to let it click in our brains. So they get a number for being male or female. So Penelope gets a 1, Stanley gets a 2. We'll say men get a higher number because men die sooner than women. Okay, they are both 65. So that gives them another, bullet or point or whatever. So they each get a 1 for being 65. So now Penelope has 2 and Stanley has 3. So in other words, how sick is Penelope? She's a 2. How sick is Stanley? He's a 3. Why? Because they're a female and they're 65. He's a male and he's 65. Now let's give them the same diagnosis. Okay, so J449 is COPD, extremely common. It carries an HCC of 111. We're not really going to think about that per se, but we can go in, and you do not have to have this memorized. It's everywhere. You can Google it, but most encoders have it. That's how I pulled up. It was actually for 2019. The J44.9 carries an HCC of 111, so I looked up 111. And it's a 0.335, but that has a decimal in it and zeros, and that's scary. So we're not going to think of it that way. Let's simplify it again. Simplified, Penelope is a 1, right? Because she's a female. She's a 1 because she's 65. So now we have 2. Now let's take her illnesses, her diseases. She has CAD, which is I25.10. She has a diabetes with a circulatory condition, so that's E11.59, and she has COPD, J44.9. So, there's the HCCs at this time, and for the cardiology, the CAD, she gets 3 points. For her diabetes with a complication, she gets 4, and for the COPD, she gets 1. So that gives her a total. If we add all of that up, gives her 10. So when you put the money involved, the little algorithm, and these are made up numbers, a 10 will say that the insurance and the payers are going to set aside $10,000 for her to be taken care of next year because she's a 10. She gets $10,000 set aside for them. So that means that whenever Penelope comes in to be treated by her provider, they're going to pull from that $10,000 that they set aside. So every time she gets an EKG to check her CAD, anytime she gets her lab work, her A1C for her diabetes, whenever she comes in to have a pulmonary study done, again, all of this is going to come out of that $10,000 that they set aside for her. Okay, let's look at Stanley. Stanley, remember, he's a 2 because he's a guy. And then he's 65, so he's a 1. So now he's got 3 points. Now he's got morbid obesity, Z68.41. He gets a point for that. He's got COPD, J44.9. Boom, he gets another point for that. And F41.1, which is anxiety, he gets a point for that. And it's an RX-HCC. I threw that in just so I could say the RX-HCC. The only difference between an RX-HCC and a regular CMS-HCC is they're not setting aside the money to treat his anxiety. They're setting aside the money for the prescriptions that he needs to treat his anxiety. That's the difference. Whereas with like COPD, J44.9, they're treating his COPD and the prescriptions all combined in there. Okay, so we total him up and he's a 6. So ultimately, Stanley is healthier than Penelope, even though he got a 2 for being a fella. It all averages out, right? His diseases aren't as problematic and don't cost as much to treat because of the HCCs. Now, so we have a 6, a total for him. So they said it's around $6,000 that they're going to pull next year to treat him. All right. That's how the RAF score works, simplified with made up numbers. And again, it looks like 0.335, and there's this little algorithm. It's really not. It's a little formula. It's not hard to use if you are needing to do it. Plus, you can have it all set up on an Excel sheet that does it for you. There's all kinds of programs that do it. So now, the CRC. The question is, how much of this risk factors do I need to do? Risk adjustment factors, the RAF score. Am I going to be doing that all the time? There's really a change in the way that risk adjustment coders or people that have their CRC work. In the past, the way it was done was you usually worked for an MA plan. And so all you did was look at a year's worth of documentation for a patient, and you just pull out chronic conditions that have HCCs, whether they have RX or not. And then you're just listing them. You're just listing them and submitting them. Okay. So again, RAF score didn't make any, I didn't even know what a RAF score was when I started working in risk adjustment. But things have changed a little bit. Now that everything predominantly risk adjusts and we need to do that budget, now you do have to be aware of a RAF score, and you have to understand the why it's done. So the who, what, when, where, and why, you have to know all of that about risk adjustment to be able to pass the CRC. There's so much more to than just picking up a code and knowing whether it risk adjusts or not, because anybody can do that. The encoder tells you whether it risk adjusts or not. So who? Are you working for an MA plan? Are you working for doing provider education? Or are you coding just for risk adjustment, but not for the MA plan who's seeing everything that's already been done, but you're right there actively working with a provider group to make sure that they're getting all the documentation they need so that we can capture the HCCs by the time it gets to the MAC. Then the RAF score is very important to you because you're educating and you're trying to make sure it's all prepared before it gets to the MAC. Why do you need to do that? Because by the time it gets to the MAC or the MA plan, it's too late. You can't make changes because they're like Optum is over in Tennessee. They don't ever get to see or query the provider. They only get to use the documentation that they've been given, and it's a year's worth. And so there's lots of missed opportunities. I mean, I used to bang my head against the wall on, I can't grab that HCC because of the documentation. So who are you coding for? What are you coding? Are you coding for HCCs for CMS, HHS? Are you doing risk prescriptions? Are you doing end-stage renal disease? Are you doing it for the MA plan or for the provider? Why are you doing it? Are you doing it to educate? Are you on the end working for a big MA plan like Optum, who has the contract for United Healthcare? When are you doing it? Are you doing it before it gets to the MAC at the providers, or are you doing it after? And I don't mean to say MACs. I mean to say MA plans. So, or are you doing it when they do the 3 pulls every year, et cetera, et cetera? And where are you doing it? So all of those things, the who, what, when, where, and why, are what is taught when you take a risk adjustment course, not just how to code ICD-10, because most people that get their CRC are already credentialed coders, and you're just specializing on the disease process. So that hopefully will answer your questions. Yes, you need to know it. You don't have to have it memorized, but you need to know the behind the scenes to be an effective risk adjustment coder. And quite honestly, it's not as hard or as intimidating once you get in there and do it a few times. Can you tell I like that subject?
Thank you, Alicia.
All right. Oh, you want to do this one?
No, go ahead, because I'm afraid to turn my camera on and mess up your internet.
Okay. Okay. So these are reviews that come in, and Boyd does a great job of capturing these very current comments that come in and reviews. And this one came in, actually, the date's not on this one. This was my third attempt. The prior attempts I did without CCO. I decided to invest in the CPC Blitz. Again, that's on sale right now. You guys, if you're getting ready to test, you got to do that. It seems like a small investment for a big return. I have no prior medical experience, as I retired from a 20-year law enforcement career and now work in health insurance industry as an SIU investigator. I followed the Blitz and spent the time needed to use the BAT system outlined. Again, the BAT technique, you can find out more about that on the website. There is no doubt this was the reason I passed the exam and increased 10 points from my prior attempt of a 66. If I can pass, then anyone can. Put the time in and don't give up or get discouraged. Sean Hill. Thank you, Sean. We hear that a lot and we appreciate it that Sean took the time to spell it out and say, this happened, this helped me. I took it 3 times. I wasn't getting it, but the Blitz, it works. If you want to see more testimonials, it's really easy to find. You can go to cco.us testimonials. And again, they're always coming in, which we truly, truly appreciate it. We have a proven process that you can look at too, that's on the website. That's how we suggest outline if you want to pass the course. Jennifer.
Hey. This one shouldn't be as long as my other one, sorry. So behavioral health, as it is on the rise, how can we correctly code Enm behavioral health claims? So there are different settings out there, hospital, partial hospital, and intensive outpatient. So there are a lot of behavioral health can be tricky. It's not as straightforward as medical, coding for, out of the other sections. It's a lot of more dependent upon the state requirements in your area. So definitely, it's kind of difficult to do in all general because each state is different. So services in mental health can be provided as Enm visits or as psychiatric or psychological evaluations. So psychiatric or psychological evaluations, they can include Enm services. However, the time associated with performing that Enm is not counted in time for psychotherapy. So psychotherapy services, psychology services, psychiatric services typically are time-based services. And as we know, Enm says, especially right now when we're using with a lot of COVID, to use office visits, there's a time to it. And next year we'll have time that we can use as a requirement. But that's not the same amount of time. So that 15 minutes for that Enm is going to be a little bit different when you involve it with a psychotherapy code. So that's where sometimes this gets a little, you go, well, is it that way or is it this way? Which one do I use? So one of the examples I found was if a patient was having problems with their medication that was prescribed, the provider can discuss what other options are available, other medications, the side effects, things like that. during the session. That is a medical component of a psychological evaluation or visit or counseling service. So it's a little bit different because that medication affects the patient, their body, their whole system. So that requires somebody with a certain knowledge, somebody with the capacity who can prescribe medication. Not everybody in the mental health field can prescribe medication. So you can bill an Enm visit along with that psychological counseling that they did. So mental health providers do use Enm when discussing, a separate medical issue, as long as the documentation proves for active management or a medical discussion separate from that psychotherapy session. Just like we've been talking about all night, can it stand on its own? Can you do this and prove that you did both? So who can perform an Enm service in mental health? So I'm talking Enm codes, and I'll show you these codes in a little bit. Psychiatrists who are MDs, a clinical nurse specialist, nurse practitioners, and physician assistants. However, some states, like I said, some states are different. Their licenses might be a little bit different for people in mental health, and they may allow different regulations. Or they may say, you're a physician assistant in mental health, but you can't do this. It's out of your scope of your license. It just depends. I don't know every state's requirement. So psychiatrists can use a code that's relevant to the location of the service. Of course, we have office services, hospital observation, hospital inpatient, emergency room, nursing facilities, telephone services, home services. Again, they are going to use an Enm code just like any other provider would, even though they're dealing with mental health. So they can still perform an Enm service. If we go down a little bit more, typically those services, psychotherapy is typically a service that they're going to provide. And those codes are 90791 and 90792. Now, some hospitals or organizations, so again, we're going back to a compliance here. What do they have set up? It depends on the facility, possibly. They may have guidelines suggesting just to use a 90792, which is a psychiatric evaluation with medical services, which is performed by an MD or a PA or one of those people who can perform a medical service. Non-medical mental health providers would use 90791, just that psychiatric diagnostic evaluation. They're looking at mental, emotional, and behavioral health issues. We're not dealing with anything medical related, and they're not prescribing medication. They're not allowed to prescribe medication. So they're just dealing with the mental and emotional side of the issue. So 90791 and 90792, of course, cannot be billed on the same day at the same time because one is a medical service and one is a non-medical service. So you wouldn't happen to have somebody doing both on the same day. MDs or psychiatrists, PA, etc., they would not use another code that's out there, which might be confusing. A 90863, the pharmacological management. Because if they do anything dealing with prescriptions, they're going to use an Enm. They're not going to use that code. There are some states that allow a psychologist with a master's degree to prescribe medication. They are the people who can use that pharmacological service. So outpatient services are going to require a written plan of care. It's going to have to involve the type, amount, frequency, and duration. Sounds kind of similar to physical therapy here. Diagnosis and expected goals. It is almost similar to physical therapy. Actually, they kind of group them together as another type of medicine. A lot of the Medicare guidelines that are out there have both of them incorporated together, physical therapists and mental health providers. A partial hospitalization, on the other hand, those are programs that are out there offering psychiatric treatment, but not at a 24-hour day stay. So they can be discharged from an inpatient, or they might possibly be at risk for needing inpatient. So they're kind of monitored a little bit more at a partial hospitalization program. And that program does have certain requirements for CMS, which if you follow CMS's guidelines, it's usually a good rule of thumb that you will most likely meet the other carriers' guidelines. Now, mental health is definitely something tricky with insurance carriers because they may use a third-party administrator to process their claims and give authorizations. So it might be harder to check into the insurance plans. But if you follow CMS guidelines, then you're usually going to meet your documentation requirements for all the other carriers. An inpatient facility, they have certain medical record requirements. So there's a checklist. I have a link at the bottom of this page. It's, again, another CMS booklet, wonderfully done, 35 pages long, so it's a lot of information. Telehealth, of course, is something that can be done right now by any of those providers in any of those locations. We can be doing telehealth for mental health right now. You might need that modifier or a certain place of service. Again, that's all carrier requirements. They might want an O2, they might want an 11, they might want a GT modifier, they might want 95, a CS, who knows what these carriers keep changing them every day. So just stay on top of your carriers and look for new guidelines coming out. A 97085 is something that people, it could be one of these codes that gets utilized a little bit too much when it's not necessary. This is interactive complexity. And people think, well, of course that patient's complicated. All doctors think their patients are difficult and complicated and special. So this describes the complication with communication during the visit. So there's some kind of problem during the visit that they cannot have proper communication with the patient, whether it's a child and they need to use toys perhaps because the child no longer speaking because of some traumatic issue maybe, high anxiety, hyperactivity, something that's keeping a barrier between the provider and the patient during that visit, making a communication problem. So we'd want to make sure that that isn't overutilized and that it can only be used with certain codes. So again, we need to look at our parentheticals, but we want to make sure that doctors understand if you see some of these coming across, well, they were highly complex. Well, what made them complex? Is it documented? What kind of problems did you have? Sometimes if they're not used to this type of facility or type of problem they're seeing, they might count them as complex because it's something they're not familiar with. So the documentations for all of those CPT codes for mental health are going to be the same as they are for any other provider. We need to make sure we are meeting every criteria, whether it's established, do you have 2 of the 3 requirements, or new patient, 3 of the 3 requirements, inpatient, 3 of the 3 requirements. So we need to make sure that we're documenting everything the same as you would any other CPT code. Now, psychiatry does have its own specialty 97 guideline printout format that you can make sure that they are documenting everything meeting the guidelines. You don't have to follow the 97 guidelines. It's just remembered 95 guidelines for Medicare are mainly medical related. So you need to make sure that they are meeting all of the criteria. And so some areas that Medicare did find lacking in mental health records that they've done in audits through OIG and RAC audits, the time is not documented. They can say counseling, coordination of care. There is a lot of counseling and coordination of care done when a mental health provider does an office visit. Just think about counseling, that term of counseling. They're taking a specific issue with that patient. And we all know anxiety and stress affect our mental or our medical body. So they're taking that to a different level than a provider would. So they spend a lot of time counseling and coordination of care. But we need to document the time and that. Missing the order when you have a consultation in hospitals and skilled nursing facilities, we need to make sure we have an order requesting mental health providers. Lack of an actual note. A lot of times providers, mental health, they're there to help the patients. They don't really think about writing these things down or using their EHR system. Lack of the required elements for the level. Remember, if you're doing an established, you need 2 out of 3 to build that level. Well, if you only have one of them, then you're not meeting the requirement. The physical exams are too brief. They're trying to build a higher level, perhaps, and they just have 1 or 2 elements of the physical exam, or the review of systems and the PFSH. Looking at that past family social medical history, they may not be meeting all the requirements. So Medicare mental health booklet, it was revised January of 2020, and it does include all of the information for partial hospitals, inpatient and outpatient services, as well as that checklist for medical records. It's very detailed, very good booklet. So if this is something that you're needing for inpatient or outpatient mental health, make sure you look at that booklet. If you don't have something from another insurance carrier, follow the CMS's rules, and they should be able to give you at least all your documentation requirements that are needed to get your Enm levels that you're looking for.
More good stuff. Boyd, do we have time for
I think you should. Yeah, forget about the back system. Just go for the last question. Sure.
Okay.
We're normally done everybody by this time at 9:30, but actually, you know what? We can. Why don't you jump ahead to the to the people who we announce our winner, because I think we're ready for that.
Oh, good idea. Let's go ahead and do that.
Winner today we've already picked, and it is Denise Lemon. So congratulations! I'll put her name in the chat. And just on the screen right there, Alicia's got what you can pick from. Go ahead, Alicia.
You get to pick either a Blitz video package like the CPC or the CRC. You can pick a year of the CCO Club Basic, or you can have an hour session, and not just with me, but they put my name on there. If you want to have an hour session with one of us, then we're more than happy to help you. But honestly, the best value is that year of CCO Club. There's a lot of CEUs in there. I don't know, like 80 or 85, I think.
Yep. So thank you. So go ahead. Yeah. Now we're going to go back and answer the last question, which Alicia prepared here. And you have the
All right. This one will go really, really fast.
Also in the webinar control panel, you have the handout from today. And if you're looking for the answer sheets, that's available for club members, which we'll talk about a little bit as well.
Yeah. Additional training for a coder. The question came in. I have completed my coding courses and I'm looking for a job, but it's taking time, especially right now, right? I know it can be a waiting game, but I don't want to waste any time. Right now, I don't want to take another coding course, but is there anything else you would suggest I do to make myself move up on a list when I get an interview? And I don't want to get a job, then find out I should have learned how to do something I never thought about. Plus, I'm over 40 now, and I'm afraid that my age will be a negative, make a negative difference. Thanks in advance, Shelley. Well, Shelley, first of all, there are other things that are very beneficial for you to know. And that being said, usually when people ask about, a career change, we get more people that are your age asking about getting into this career, this medical aspect, and then people that are fresh out of high school, because they seem to have much more options, things that they want to get involved with. So age is not a problem. Don't worry about that. I'll tell you more about that in a second. However, it is important to learn some basics that I know you're going to use a lot, especially if you work remote. But even if you don't work remote, most organizations, most facilities, they get Microsoft Office they get a huge discount. If you think about it, if you're working for a hospital system and then they have clinics, everybody's going to use Outlook Express because they're given Microsoft at a significant discount platform. I know that when my husband was in graduate school, he got the whole Microsoft Office Works for $10, the latest version that had come out. Now, mind you, that was a few years back, but it was something that they gave the graduate school, so, and they told them to give them to all of their students, and that's when it came out on a CD. So, I mean, that was really cool. And that same thing happens with hospitals and doctors' offices. The number one program on that I would suggest that you learn about is Excel, especially when you work remote. But almost every contract job I've ever done, even working for CCO, any type of coding, you're probably going to end up working with Excel sheets, spreadsheets. Now, when I went to college, I took a computer class and they taught you how to use Excel. But honestly, I didn't like using Excel, so I only learned what I had to pass the class. And there were people that really enjoyed it, so they learned how to make all kinds of graphics and fancy things like that. But the basic Excel looks like this, you know, and again, it's not real big, but you can go get this. These are just free images that are offered on Google. So there's columns and rows, and each one of those little squares is called a cell. And you can manipulate them and put content in them, and it's amazing what you can do. Even if you learn how to put in only a whole bunch of patient names and then alphabetize them, you can put you may be given a list of providers that you need to code for in a specific clinic. So say it's a cardiology clinic and it's a whole list of providers for that clinic, and you need to separate them out from the family practice providers. And you can do that. You can have all of the doctors put in there and then alphabetize them either from A to Z or Z to A via their last name. You can alphabetize patient lists. You can abstract out codes that are used and pull, like, everybody that has hypertension, I-10, I want that, you know, highlighted in red. And all of this stuff does it. Not only that, there's a lot of uses for Excel when you're doing budgets and stuff like that, because you can actually put in math problems. So you can tell it to say, you know, it's a graph. So you can say A1 plus you know, A2, I want A3 to tell me what those two numbers equals. And there's a way to put an equation format and stuff. But this view is just an example of one of the things that you can do where you actually put all of this data in, you data entry it in, and then it will come up and create these pie charts and fancy stuff. You're probably not going to be doing that unless you get into administration and supervising and things. But it's a very easy way for coders to capture codes and put them in these columns and keep track of how many risk adjustment scores the patient has, or how many diagnoses that patient has, or when they need to come back in again. This is, again, a bigger view of what it looks like, and it can look intimidating if you've never seen it before, but I want to assure you that there are tons of free lectures out on YouTube on how to use Excel. So take advantage of that and learn the basics, because what will help you is if you know how to put in a whole sentence, and you want that whole sentence to fill up that square and not go across, or them not bleed into each other, or format and color code and so on and so forth. So easy to learn this stuff, but if you don't know the little tricks to do it, it's very time consuming and intimidating. And if you're going to be a coder, especially remote, I guarantee you're going to be using Excel spreadsheets at least once, and probably daily. So that would be a program I would encourage you to look into and just bring your knowledge up so that when you have on your resume, hey, I'm proficient with Excel, they're going to go, well, I don't have to train the person to do Excel because that's annoying. I'd rather train you to do the job, not have to train you to use a basic program that we all use. That being said, if you don't use Outlook, you might do some research because that is an email platform that almost all people use, as well as some other that come with Microsoft, like Notes and Teams and things like that. But definitely use, see how familiar you are with the different Microsoft applications. Now, also, I think I put on here, let me just tell you real quick, let's see, networking platforms, professionals like LinkedIn. You need to get involved with those. Facebook, just about everybody uses Facebook and stuff like that. I'm not talking about that, and Instagram and all that other stuff. We're talking professional, like LinkedIn. Indeed, I think, is one for jobs. There was places to get your resume tweaked, and we did a webinar here a while back and did an interview with Annie, who has a program to do that. But again, Microsoft is going to be your number one. As far as age is concerned, look at these cute graphics I got of this fella and this lady as they age. You in your 40s are prime age for this career. Definitely there are more women that do this than men, but it is growing as far as men. It's kind of like nurses. Everybody was female for a long time, but now there's a whole lot of male nurses. And we want to make sure we give them shout outs and encourage them as well. But not very many young people, not fresh out of school, whether high school or even college, that are in this aspect of the medical field. And it is a well-paid, fun area to be in, that now you do get to work more often remote. I couldn't have said that 5 years ago. Once you do get your foot in the door, people don't leave. And that's why it's harder to get your foot in the door and get those jobs, because it is such a fun career to be in. There's so many niches that you can go into. It's never boring. Just like Jennifer said earlier, if you work for a PCP, you're going to see everything. If you work in an ER, do ER coding, you're going to see everything. You're going to learn about diseases and disease prospects and treatments and drugs that work for things. And being a little bit older, having some life experience makes you more marketable than somebody who is getting their first job. So until you can't sit in a chair anymore and sit up, and then even if you can, because I happen to know some paraplegics who are fabulous coders, So if you have difficulty standing on your feet for long periods of time, this is a great career path for you. But being a little bit older, being in your 40s, 50s, and 60s, prime age for this career path. And that's it.
Thank you, Alicia. And we are now finished our regular part of the webinar, and you can talk just a second here about the CCO Club. If we talked about it a little bit, but a lot of people are asking about these handouts and how come they don't have all the answers and all the answer sheets and all that kind of stuff. Maybe you can briefly do that, and then we have 2 questions, I think, in the Q&A chat.
The handouts, is just the slide deck that you're actually seeing here. All the answer sheets are exclusive content for our club members. And so, yes, you can go back, you can look at the video again, and you can get the information. We give it to you free. But if you actually want copies of that, then again, that's one of the perks of being a club member. That community is able to go in there and discuss the things that we talked about tonight in the forums. We also use the content to package CEUs, so we don't do just like 1 CEU at a time, or 1.5 CEUs. No, we give you 5, 10 CEUs at a time, and we combine content so it's all pertinent and applicable. So if you're wanting to get a CEU for compliance, or you're wanting to get one for billing, then again, you can go in and and get multiple at once. It's time saving. We do have a survey that we'd love for you to fill out if you're able to and are so inclined, because it helps us do better. We don't advertise, really. It's word of mouth. And so if this has been helpful to you, then please do the survey. Tell us that. If you think we need to improve something, absolutely let us know. You are why we do this, besides the fact that we enjoy what we do. We already picked our winner. And now we get to go to our chat. Sylvia and Lori have been in the background answering lots of questions in the chat. Let me just go pull that over. I think she pulled some.
Sylvia has
the webinar is officially over.
Been working on the survey questions while Lori's been in the chat and social media, and apparently Sylvia's got golf ball size hail or raindrops, I forget what it was, coming down right where she is.
Sylvia and I used to live in the same town, and she's like 3.5 hours west of me, and there was supposed to be a huge storm coming in, so gee whiz. It's like the sky is falling, literally. Again, the webinar is over. If you want to stay, you can. We'll answer some of the questions that came up while we were chatting. This one is coding cancer. Do you code cancer as history if the provider reviewed a PET scan and stated there's no recurrence of the disease and the patient is not on any treatment? Yes. Yeah, you would be able to use that as a history of. And again, the provider doesn't have to state history of, prostate cancer. If he looks at a PET scan, it says PET scan reviewed, no reoccurrence of disease. The patient is no longer on treatments. That is stating history of. It doesn't actually have to state history of. He's giving the information that meets the description of history of, and so therefore you can code that. And again, even if the patient is taking a medication that is a prophylactic one, where they're just giving it to them so they don't get it back, decide. But yeah, it's still a history of. And a really good book, Sherry Bernard Poe did a risk adjustment book. I'm looking at it. I got more than one copy over there. A second edition just came out, Risk Adjustment Documentation and Coding, and she talks about it pretty extensively too. So I would encourage you to get that book. Alzheimer's dementia. Hey, we just did a video on this the other day. When a physician documents Alzheimer's dementia with increased restlessness, fidgeting, and hallucinations, do any of these support F02.81, or only if the physician uses the term behavioral disturbances? No, in my opinion, and this is my humble opinion, that meets the definition, behavioral disturbances. But remember that behavioral disturbances has a wide range. It also means that the patient is gets upset easily. So most people think that behavioral disturbances means they're lashing out and in their confused state, and that is true. But all of those things that you've listed, the restlessness, the fidgeting, the hallucinations, that's behavioral disturbances as well. But don't just take my word for it. What you need to do is have a meeting, come together and decide that, yes, that's what, we understand that as meaning, because if your provider documents it this way, this time he's going to, he or she's going to continue to document it that way. So query, make sure that it's meeting the definition, and then go forward with that, and then have everybody have a meeting, sign off on it, and then you won't get dinged for it.
Can you repeat the book again and author?
Oh, it is Sherry Bernard Poe. And the book is actually the textbook we use for our risk adjustment course. It's fabulous, second edition, and it's titled, I'm looking over here, Risk Adjustment, Documentation, and Coding. It's the 2020 version, and it's put out by the AMA. So you can go to the CCO.US website, and you can look at our CRC course, and it will tell you the textbook that we use, and that's it if you want if you forget to write it down. It's an excellent book.
Thank you.
It not just for risk adjustment, but it's got a lot of really good information for ICD coding, and the guide going over the guidelines, because you comply to those guidelines in risk adjustment. And so I would add that to your library. It's a book that we were so pleased with that we adopted it for our textbook. It's that good. Is there another question? Or was there just the two?
Nope, that's it.
Put two. Yep.
Oh, Jennifer didn't even get a chance to say anything.
She probably thought it'd take you longer than that. No, they were both coding ones. They were for you. They were right up your alley.
Usually, Jennifer, she gets a lot of the ones that's like, oh, I don't want to answer that. I'll just sit here and nod and smile when I know what I'm talking about. That is another thing that's great about this career path is, you'll get in there and you'll think that you're going to really enjoy something, and you find out, hey, I didn't enjoy that as much as I thought. When you're taking your courses, you realize that too. But like I'd said before, I've done the provider coding and use the CPT codes and stuff like that, and I can do it. I just don't enjoy it as much as I like diagnosis and codes and risk adjustment and things. So you notice I always like grab those questions first, and Jennifer's always doing those billing and courses because she really enjoys billing. If you guys are needing a lecture for your chapter, your local chapter, we have a lot of titles that you can pick from. These are actually, we've updated them and put in a whole bunch of new ones. Jesus did that the other day. And feel free to go check out cco.us/remote-presentation. And again, right now during the pandemic, we're not doing any live remote presentations. They are recorded. They have been approved for CEUs, so it'll be easy for you to get them approved again. Lots of topics to pick from, and a very easy process. Lori helps kind of walk you through it, and you can live stream it to your group. Don't forget that survey that we told you about earlier. It really helps us. And another thing that truly, truly helps us is when you tell other people to come and check out our videos on YouTube, check out our CCO Club, our website, and take our courses.
Well
and
said.
Then more about the CCO Club. We also are on Facebook, guys. Really easy to find us. It's just facebook.com, cco.us. Always got some interesting stuff happening in there, but I think more happens on our YouTube channel.
And look at that number. We're so close to 4 million views. Very, very close.
Oh, you guys,
so go watch
help
some
us
YouTube
get to
videos
4
tonight,
million.
guys. Yeah.
Wouldn't it be great if by next month, let's see, our next Q&A monthly webinar will be on, what is it, like the 18th, I think? Maybe, that we had 4 million views. Help us have that happen, guys.
We'll hit that pretty easy. We also have we have a celebration in our live streams during the week coming up. I think we're going to hit 60 in CCO Club and student webinars, right?
Good, good.
Strange,
I love that.
I don't know what we're going to do, but you've been talking about it, so remember that.
Yeah, I keep saying, get us to that. Let's have a celebration. Let's have a party. We'll think up something really, really fun to do. We have a whole lot of other links that if you want to go to the cco.us, we have sales. We have that proven process. Lots of freebies. We have a whole page of different freebies. Free practice exams. Start taking those. If you can't go test, take our free practice exams. We of course have our courses and Facebook and YouTube. Let's see, the testimonial, and again, share with your friends. We do a lot with LinkedIn. Go find us each on LinkedIn and say hello to us. Do you have both a HEMA and AAPC CEUs in the club? Yep. We sure do, because now they use each other. We have AAPCs, and whatever AAPC takes, a HEMA takes. So just submit it or ask, and a HEMA usually takes them. Yep. Thanks, guys. Anything else, Boyd?
No.
Happy learning.
You guys did great. Thank you. The internet seemed to hold out for everybody. Thank you, Jennifer, for
Yeah.
being flexible there.
All right, until next time. So we'll see you close to, well, earlier than this, but Tuesday nights, Thursday nights, and the second to the last Thursday of the month. And sometimes we'll throw in a CCO club, CCO live in there on a Wednesday once in a while.
Keeping it real.
Yeah.
Night, y'all. Thanks for being with us. Really appreciate you taking your time out of your day to be with us and celebrate being a coder.
Share with your friends.
Yeah. All right. See you guys.